Cytomegalovirus, or shortly known as CMV, is a DNA virus that belongs to the herpes virus family, like herpes simplex, varicella zoster, and the Epstein-Barr virus. When CMV infected the body for the first time, it causes a primary infection, and then remains dormant inside the human body for life. This dormant virus may be reactivated later at any time, causing another episode of infection. Also, infected persons may be reinfected with another CMV strain. Reinfection and reactivation are called non-primary CMV infection. At least 60% of the US population has been exposed to CMV infection, and it may reach up to 100% in certain geographic areas, depending on ethnicity and socioeconomic status. CMV is asymptomatic in 90% of cases. Other patients may develop non-specific symptoms like fever, rhinitis, pharyngitis, myalgia, arthralgia, and headache. CMV is the most common congenital viral infection. About 1% of pregnant women acquire the infection for the first time during pregnancy, and about 1 out of every 150 babies are born with congenital CMV infection. CMV is asymptomatic in 90% of cases. However, the main risk is that the virus may be transmitted from the mother to the fetus, causing a congenital CMV infection. This risk depends markedly on whether it is a primary or non-primary infection. In primary infection, the risk is 40% chance that the virus will pass from the mother to the fetus. However, in non-primary infection, the risk of fetal infection is only 1%. But how can we differentiate between primary and non-primary infection? First, we have to understand the serology of CMV infection. When the virus infects the body for the first time, the immune system will produce immunoglobulin M, IgM, and about 2 weeks later, it will start to produce IgG. The IgM level will increase rapidly, peak at around 1 to 2 months after exposure. Then it will start to decrease until it becomes undetectable after about 6 months post-exposure. Similarly, IgG will increase rapidly, peak at around 1 to 2 months after exposure. But in contrast to IgM, IgG will remain detectable for life. Any time in the future, if non-primary infection happened, either due to reactivation or reinfection, this will result in another episode of IgM production similar to the primary infection. This is the classic pattern of CMV serology. However, another pattern may occur with primary infection, which further complicates the situation. When the IgM remains positive after the primary infection for a long period, which may reach up to 1 year. There are 4 possibilities. The first possibility is both IgG and IgM are negative. This means the patient has no prior exposure to CMV, and any infection during pregnancy will be a primary one with a 40% risk of fetal infection. The second possibility is IgM positive but IgG negative. This may indicate a primary infection. However, take care, this happens only for about 2 weeks during a whole person's life, and you should be lucky to request testing during this very short period. In addition, false positive results are common and may occur with other viral infections like parvovirus P19, Epstein-Barr virus. Also, it may occur with other autoimmune diseases. So in this case, repeat testing is required. The third possibility is IgM negative but IgG positive. This is an old infection with no risk of fetal CMV infection. The fourth possibility is the most problematic one, when both IgM and IgG are positive. This may reflect a primary infection or non-primary infection. But how to differentiate between primary and non-primary infection in this case? The answer is IgG avidity. Avidity means the strength of binding between antibody and the antigens. As IgG mature, its avidity increases from low to moderate, and lastly to high avidity. Low avidity IgG antibodies are found only after primary exposure and usually last for about 16 to 18 weeks after the onset of CMV infection. An avidity index less than 30% strongly suggests a primary infection of less than 3 months, but high avidity, more than 65%, suggests that the primary infection occurred more than 6 months in the past. And currently the combination of IgM antibodies and low IgG avidity is used for the diagnosis of a primary maternal infection. If the mother acquired CMV during a pregnancy, the risk of fetal infection depends on 2 factors. Firstly is the type of infection, whether primary or non-primary. Number 2 is the gestational age at the time of infection. CMV transmission rates increases with advancing gestation. However, the risk of fetal complication is lower with advancing gestations. One study found no symptoms of infected newborns when the mother acquired the primary infection in the 3rd trimester. What are the manifestations of fetal infection? Like adults, most fetal infections are asymptomatic, and 90% of infected babies will be delivered without clinical abnormalities. However, 5% of those apparently normal fetuses will develop neurologic abnormalities later. Symptomatic infected fetuses may have IUGR, microcephaly, hepatosplenomegaly. 1/3 of them will die, and the majority of survivors, about 90%, will have long-term disabilities such as mental retardation, learning disabilities, cerebral palsy, epilepsy, hearing or visual impairments. How can we diagnose fetal infection? It is by amniocentesis. When the virus passes from the mother to the fetus, it will replicate inside fetal tissue and be excreted through fetal kidney into amniotic fluids. Amniocentesis means obtaining a sample of this amniotic fluid to be tested for CMV DNA. The timing of this test is very important. It should be performed after 21 weeks gestation, as fetal diuresis is not established until then. Also, it should be performed 6 weeks after the presumed infection, because the virus takes about 6 weeks to pass from the mother to the fetus, replicate, and being excreted in the amniotic fluids. If fetal infection is not diagnosed, it's okay. The baby is one of the 60% non-infected fetuses, and the mother could be reassured. However, if fetal infection is diagnosed, serial ultrasound examination should be performed to find affected babies. Ultrasound features of fetal damage includes microcephaly, ventriculomegaly, intracerebral calcifications, ascites, hydrops, echogenic bowel, IUGR, and oligohydramnios. During a pregnancy, there is no proven effective treatment for prevention of fetal disease or reduction in fetal complications. Antiviral drug like ganciclovir has been tried with no beneficial effect. In one study, it was found that the rate of neonatal infection in treated and untreated mothers was equal. Hyperimmunoglobulin is another drug. It has been used in few studies with a promising effect in some of them, but generally it is not yet recommended to be used during a pregnancy. Young infants and children with subclinical infection are the major source of infectious CMV. And about 50% of children who attend daycare actively shed CMV virus in their saliva or urine. Thus, daycare workers are at high risk for infection. Preventive measures include washing your hands regularly with soap and hot water, particularly if you have been changing nappies or if you work in nursery or daycare center. Not kissing young children on the face. It's better to kiss them on the head or give them a hug. And not sharing food or eating utensils with young children.